everyone. We are now going to go over the bone marrow flow cytometry plots from a 68-year-old man who presented with anemia and lytic bone lesions. So we're just going to jump directly into the plots that have the money. Patient with anemia, lytic bone lesions in the old age, we would suspect in the heme path aspect, we would suspect a plasma cell neoplasm. So that's what we are going to see. So this is a plasma cell tube. Plasma cell tube is different from the other tubes, usually an add-on tube or a specific tube for certain cases, because in your regular B cell tube, we analyze for the surface kappa lambda light chains, but in the plasma cell tube, we analyze for cytoplasmic kappa lambda light chains, because if you remember, plasma cells do not express surface light chains. Their light chains are only seen in the cytoplasm. So most labs do not even perform a regular full myeloid and lymphoid panels for cases where they suspect plasma cell neoplasms. They just run the plasma cell tube and then they will correlate it with the morphology and release the report. So this is one such case where they just did the plasma cell tube, because you have your bone marrow morphology, and if you see plenty of plasma cells, then that's probably enough to do for flow. So in our plasma cell tube, CD38 is our main marker, because CD38 is brightly expressed in plasma cells, and no other cells in the peripheral blood or bone marrow express CD38 at the level of intensity which the plasma cells express. The NK cells are also positive for CD38, and they express slightly dimmer CD38 than the plasma cells. Plasma cells CD38 is the brightest. So we usually gate the cells that are very bright for CD38. So some labs, they use CD45 versus CD38 for gating, and they will get the population that is bright for CD38 and dim to negative for CD45, because normal plasma cells express CD45, but neoplastic plasma cells lose CD45. So they use that to gate the aberrant plasma cell population. And when we get these cells here that are painted blue, we see that they are negative for CD19. So that is aberrant. Normal plasma cells express CD19 on their surface, and neoplastic plasma cells are negative for CD19. And this is a plot that shows CD38 and CD20. We can see that the CD38 positive cells do not express CD20, and these are the B cells that express CD20. And we see that our plasma cells, which are painted in pink here, are kappa restricted. And so that is, again, abnormal. We have monotypic kappa restricted plasma cells that are negative for CD19, and they express the aberrant markers 117 and 200. They express partial CD56. So all these are aberrant markers, 56, 117, 200. We don't expect to see them on normal plasma cells, and they are expressed on neoplastic plasma cells. They can be variably expressed on reactive plasma cells, but reactive plasma cells are polyclonal. So when you see this expressed on a monotypic plasma cell, then those are aberrant markers. This is just 138 and 38 showing that the plasma cells are positive for CD38 and CD138. So we have a plasma cell population that is monotypic and with expression of aberrant markers. So this is clearly a plasma cell neoplasm. We can see that. And based on the numbers that we see in the bone marrow, they can be either plasma cell myeloma or multiple myeloma. So one thing that you have to remember is, once these patients are diagnosed with plasma cell neoplasm, most likely they are going to get daratumumab. So daratumumab is a monoclonal antibody to CD38, and subsequent flow cytometry can sometimes be challenging, because there are steps that you can use to wash dara to remove that dara that is attached with the CD38. But if it is still sticking to it, daratumumab itself can look like a kappa restricted, can give a kappa restricted picture, because those are those have kappa light chains. So that's something that you have to remember. Another possibility is, when the patient is on DARA, CD38 can be negative, and you cannot use CD38 to gate your plasma cell population in that scenario, and you have to rely on CD138 for those cases. So these are just two things that you can remember. And always mention the percentage of plasma cells that you see in the total specimen, and the percentage of aberrant plasma cells that you see. And one thing is like plasma cells are very vulnerable to lysis, and the number that we get in from flow cytometry is often an underestimate. Even if you see like 60-70% plasma cells in your bone marrow, you won't see that number in your flow cytometry. Flow cytometry will show 80% or 10% plasma cells. So you can just report plasma cell myeloma or plasma cell neoplasm or this percent aberrant monotypic plasma cells identified. Thank you.